Of course, this is our heart MRX monitor. It is an AED and defibrillator that we use on the ambulance. To begin your shift, you want to test that it is running properly. You want to turn it on to adult dose 150 and wait till it starts up and plug in your test resistor just so I can demonstrate. Go into the menu, go down to other, operational check, run op check. You need to acknowledge. At this point you can check your printer paper to check there is enough for the shift. There is heaps, and that will just do its thing. In the meantime I can run through what's in the pockets. In this pocket we have our drugs, we have aspirin and GTN, we also, which we need to check the expiry dates on. At this point it's asking me to charge and administer a shock.
Shock delivered.
It's asking me if I heard that shock, and you just click yes. And yeah, you want to check the expiry dates of the drugs in here, and you also have a razor in case you need to shave a patient. We also have our heart start pads in this pocket for resus. In the back pocket we have spare printer paper, we have different sizes of blood pressure cuffs, we also have spare batteries, and in the back of the machine you have 2 batteries that the machine uses. There's a button on each battery which you can see the charge on it. You can also see the charge at the top here. You can see that the B battery is running quite low at the moment, but we still have lots of battery on the A. If we're on shift we would change the B battery. That is still going. Over on this pocket we have our end-tidal CO2, end-tidal CO2 which is plugged in up here. At the top here it measures the CO2 on exhalation. Over here we have our SpO2 monitor which just pops on the patient's finger. You want to ensure the patient's finger is clean and free of nail polish, and that just measures the oxygen in their blood. We have our blood pressure cuff. It's a non-invasive blood pressure cuff which works the same as a manual one. You just pop it on the patient's arm and it measures the systolic and diastolic pressures. And over here we have our 12 leads. This is to measure for the ECG. We're going to use the 3 lead today, which has 4 terminals which you place on the patient's body. You just want to check that they're all not tangled and ready to use. Our operational check has passed, so it's just going to print out a report for us. This is our CPR pup, which can be used in a resus to check our effectiveness of chest compressions. And I'll just continue printing out. It's just a report in paper form, just to show that we checked everything. Right, so just want to exit op check. At this point you can turn it on to on monitor. We want to unplug the test resistor and plug back in the heart start pads in case we need to resus quickly. At this point we can plug in our, pop these on our body, on the patient's body. So we've got right leg, which I can just place here. Left arm. This up here, you want to avoid any bony areas because that can give a false reading. You want to ensure that the patient's body is free of hair and is dry, so it gives a good reading. That was the left leg and right arm. And you can see it will start measuring my ECG. My heart rate's a little bit all over the place. So you can see the ECG is up here. You can see my SpO2 would read here. This is where you pop the blood pressure cuff on the patient and you can start MVP, which will start the blood pressure. You can change the displays on this. You press this button here and it will show different ways, different displays. You can turn the audio off. At this point you can also, on the ECG machine, you can change the volume. So you can click menu, volume, go down to QRS. You can have very loud, and at this point you can measure your radial pulse and correlate it to what the machine is doing to check it's working effectively. You can have it very soft or you can just turn it off entirely. Also what you can do is you can change the display of the waves. So you can go display waves, wave 1, let's do this one, and you can change the size, so you can have ×4, or we usually just keep it at ×1 because that's what everyone uses. Cool, so what we can do now is change it to adult dose. If we wanted to give a shock, I'm just going to plug in the test resistor. If we want to give a manual shock, we would go into adult dose 150 joules, we will go charge and it will charge. Once that is finished, it will tell you to shock and it will deliver a shock. If at any time you want to disarm the shock, you can go charge and put disarm down here and it will stop the shock so it won't shock. So it will just keep printing out my ECG. If you are working on a patient
15 seconds without sign of
cardiac arrest, you can turn it straight on to on AED
Analyzing
and just follow the prompts and that will
do not touch the patient.
tell you when to shock. they need it. This is our first response kit. In this outside pocket we have crepe bandages, 2 types of transport tape, steri strips, triangular bandages, combine dressings, gauze squares, saline ampoules and tourniquets. In this pocket is just a miscellaneous pocket. There's blueies in here. In this pocket is our diagnostic pocket. We have stethoscopes, blood glucose meters, adult and child blood pressure cuffs, pupil torches, clothing chairs and thermometers and their covers. In this pocket over here is our glucose control pocket. We have oral glucose sachets, glucagon, glucose 500 ml, a giving set and a 16mm syringe. In this pocket over here we have emesis bags, methyl chloride spray, N95 masks and a cervical spine lanyard. In the big pocket we have our towels, sharps container, cardboard splints, collar, transfer belts, slippery sands. We have our saline and giving set, an IV roll, our LMAs, adult and paediatric bag valve masks. Then up here we have our nebulizer masks, bowls and tubing. We have over here our adrenaline, salbutamol and ipratropium. In this pocket we have our NPAs and IPAs in all different sizes. We have a biohazard mask, bag, forceps. We have lube and what else do we have in here? Laryngoscopes. That is what we have. In this pocket we have, as our drug pocket, we have tramadol, paracetamol, ibuprofen, methoxyfluoride, loratadine and ondansetron. This is my oxygen tank. I can tell it's oxygen because it's white with a black cap. It'll sometimes be labelled. This is my regulator. Inside it has a Bodex seal and I'm just going to place it on the oxygen tank to check it's in good condition. You can tighten it up all the way. To turn it on, I'm just going to turn this cap, and for the sake of this video this oxygen tank has no oxygen in it but it will turn to full. I'm just going to turn this dial here to check it has a good flow rate. I'm then going to turn off this cap and let the lines bleed out before turning it back to 0. This is my high concentration mask. I'm going to check the tubing is all intact and not kinked. I'm going to attach it to my oxygen tank and turn it on to a flow rate of 10 litres per minute for this mask. I'm going to place this mask over the mouth and nose of the patient. I'm going to pinch the nose and ensure it has a good seal. Either I'm going to hold it or the patient is going to hold it. I'm going to check that the reservoir bag stays inflated. You would give oxygen for a traumatic brain injury if the patient is in shock, has respiratory distress, carbon monoxide poisoning, saturations under 94%, or if the airway is obstructed. To take off the mask, I'll just remove it from the patient's face, ensuring that it is still turned on when you're taking it off, to ensure the patient isn't deprived of oxygen. I'm just going to turn this off this dial, let the lines bleed out before I turn it back to 0. I'm going to remove the regulator. This is my suction unit. I'm going to check the tubing is not kinked and in good condition. I'm going to turn it on full and just check it is working by kinking the tube. You can see it has full battery and I'm also wearing my correct PPE, my glasses and my gloves. Now you can see it has reached maximum pressure. That means it's working. I'm going to unkink it. We're going to ensure our patient is in a lateral position so that gravity can work in our favour. For the purpose of this video, the mannequin can't be placed in a recovery position, and so we're going to have him on his back with his head tilted to the side. To suction, you want to insert the catheter covering the hole, without covering the hole, sorry, only as far as you can see. So you're going to place it in the mouth and suction on the way out in a circular motion. You only want to suction for 10 seconds maximum in case of any breathing interventions and to minimise damage. You never use it in a moving vehicle. Some complications that arise is if the patient has trismus and you can't access the mouth. In this case you can use a smaller catheter that's smaller and softer to suction through an NPA. You can also use this in paediatrics. If there is large foreign matter present and you can see it obstructing the airway, it might be best to put the head on the side and use a finger sweeping technique instead, as the catheter is the head is quite small. When we come on to shift, we want to check the bag valve mask is in good condition and working. We're just going to block the end and pump the bag up. We're going to take the reservoir bag off and pop it on the end of here. Just hold it on there and pump it up to check there's no leaks in the bag. Seems to be in good condition. Pop it back on the end. This is an extension and a filter that we need to pop on here before we put the mask on. This mask will fit the size, fit the patient's mouth and nose. We're going to check the tubing isn't kinked and is in good condition and not ravelled like that. And then one end goes onto the BVM here, and then the other end plugs into the oxygen tank when you need it. We're responding to a 65-year-old male who's collapsed after having chest pains. We go on, can you start the first response kit and the BVM equipment, please? Yep. And if this is a resus, can you start chest compressions while I manage the airway? Yep. Cool. We're going with our oxygen, our AED, our suction unit if we need it, and our first response kit. We're going in with our gloves and our glasses, PPE, and we're aware of any dangers before we go on scene, and there appears to be none in this case. Okay. Hi, we're from the ambulance. Can you hear me? Can you open your eyes for me? I'm going to check the airway. Seems to be clear. And I'm just going to check the breathing for 10 seconds and chest rise. There appears to be none. Alan, can you start the compressions, please? Yep. AUT the comms, can we have an R50 for an R49, please? Right, I'll work around you setting this up. Alan.
Analyzing heart rhythm.
Can you stop?
Do not touch the patient.
Putting in the stuffing position, so we're in a good position for airway.
Shock advised.
Back on CPR, please.
Charging. Stay clear of patient. Deliver shock
Stop.
now.
CPR, please.
Press the
Everybody
orange
clear?
button
Shocking.
now. Shock
Shock
delivered.
deliver. Back on CPR, please.
Pause. Start CPR.
At this point in the resus, we're going to insert an OPA and the NPA. An OPA goes into the mouth and you measure it from the mouth to the mandible. You insert it upside down, rotate it 180 degrees. And indications for that is that mercy is lower than 8 and if you need to use manual airway intervention. Contraindications if you can't gain access to the mouth due to trismus, you use an NPA. An NPA you measure from the nostril to the earlobe. You insert it straight down into the largest nostril. Indications for an NPA is if a high UCS, and if you can't gain access to the mouth. Contraindications is if there are skull fractures. We're then going to use a bag valve mask in this case, because you can deliver 10 to 15 RPM at a rate of 100% of oxygen. I'm just going to turn the oxygen on. We're going to use 15 in this case, RPM. And we're going to place the mask over the mouth, ensuring a good tight seal. Issues with this might be facial trauma, facial tear if they are obese or elderly. I'm just going to use a C-grip. And can you start counting out loud, please? When we inflate, we're going to make sure we don't overinflate the chest because that can cause damage.
3, 4, 5, 6, 7, 28, 29, 30.
We've got good chest rise there. And I'm not getting a good seal though. Can you use the bag valve mask this time? I'll use the C grip.
28, 29, 30.
Perfect. Next time it analyses Alan, I'm going to do the contractions.
Stop CPR.
I'm going to go in front, you go back. Stop CPR.
Analyzing heart rhythm. Stay clear of
Stay clear of
patient.
patient.
Analyzing heart rhythm. No shock advised.
Start
Pause.
CPR again.
If needed, start CPR.
So we're going to make sure we go at a rate of 110 beats per minute. We do 30 chest compressions to 2 breaths, and we go a third of the depth of the chest, and making sure to recoil. I'm going to start counting out loud. 1, 2, 3. At this point in the CPR, we can ask the watchers.
28, 29,
30. Yep. We can ask whoever has seen what's happened, what happened prior to the event, what medication he is on, if he has any medical history or has this happened before, any allergies. 30. Thanks Alan for counting for me.
Can I get you to do the breakdown last?
Yep. 6, 7, 8, 9, 6.
do you want me to squeeze this?
Yes, please. 30. 1, 2, 3, 4. Are you getting a good step?
Yep, cool.
Stop CPR.